this road, and I lay down my heavy load. Let the love I've shared speak for me.
I was thinking if you're around when my time comes, you can sing that second song for me. That really spoke to me. I'm going to invite the real guest of the program this evening, which is Ellen Jewett. And this is a picture of her and her beautiful husband, Willem. This is really important because while I'm here giving a talk, it's really not about me. It's about patients and about patients facing the end of their lives and wanting to have some say in how things go. And I am really grateful that Ellen has given me permission to share Willem's story. Actually, Willem gave us permission to share his story because he was an advocate till the end, and she's here tonight. This is Ellen Jewett, wife of Willem, and that is a picture of them. And even though tonight we are talking about the end of life, we are mostly talking about life, and I want you to keep that in mind by looking at that beautiful picture. All right, great. So obviously, this is a mixed audience, and mostly I want to leave plenty of time for questions because I really want it to be a conversation. I'm here to provide you with information, and that's best done if I get to answer your questions. But I do want to make sure that we're all holding the same core group of facts and information. So I'm going to spend just a little time talking about medical aid and dying, and then we're going to hear a little bit about Ellen and Willem's love story, and then we'll have plenty of time for questions. Sound all right? If I say something that doesn't make sense or you have a burning question at any point, please don't hesitate to raise your hand. I should be very clear that tonight we're talking about medical aid and dying, which is one option of many when people are navigating the end of their lives. It is voluntary for patients and for providers. We may have people in the audience who would never want to make use of it, and that is completely okay. We may have people in the audience that are pretty sure they might want to use it, and that's also okay. But as a palliative care doctor, I'm here to tell you that most of us are going to fall in the middle. And what that means is we don't know what's going to happen as we're nearing the end of our lives. We don't get to pick what disease we have or what challenges we have or how we suffer. And it's because of that I am an advocate for, because I grew up on a farm, lots of tools in the toolbox. So we want to have lots of things available because everybody suffers in different ways. So my goal for this evening is not to convince you that this is right or wrong or good or bad, but that it is one of many tools in the toolbox, and hopefully you'll have a deeper understanding of what it is. Because I don't get to talk often enough in public about palliative care, I have to just do my one little slide about that. So there's a lot of misperceptions about lots of things in our society, but especially about dying. And we don't like to or tend to talk about it a lot. But it does happen to all of us, and it is a discrete event. It is a moment in time, and many of us have thoughts about how we would like it to go if we get to have a say. This circular diagram is to remind you that hospice is that middle circle. It's a big circle, right? Hospice is about living well until you're dying. So again, because we sometimes mix up our words and we don't like to talk about death, sometimes it's easier to talk about hospice, and then people think hospice is about dying, but it's not. It's about living fully the final chapter of your life and having a good support network to give you every reason to make the most of every single day. And then you can just take that concept and broaden it to what palliative care is. Palliative care is even bigger than that. So it is a supportive service for people who are living with serious illness. And that's it. And we can be helpful for people at the time of a serious illness diagnosis, as you're trying to wrap your head around what's happening. Say you get diagnosed with ALS. We can be supportive as you're progressing through your illness to help with symptoms, to help you cope and adapt to change. And again, make the most of every single day. But again, I will caution you that because we're not very good about talking about dying, and we tend to equate dying with hospice, now we're tending to equate palliative care with dying, and it really isn't about that. It's about living fully. And if you learn nothing else from tonight except that, I'll be grateful. And that circular diagram is just a way to make it really easy. Dying, hospice, palliative care. Got it? So how we come to the end of our lives is a little bit different now than it used to be. So I found this beautiful picture of how death sometimes looked prior to the mid-1900s. And in this picture, you can see sort of several things. First of all, the person who is apparently dying looks pretty healthy and young. She is surrounded by her family. Some people are sad. People seem to be accepting. Looks like a home. Looks like they're just making the most of their time. This is all too often how it looks since then. Now, this same picture, which in case you have trouble visualizing, I'll just show it, somebody lying in a bed with a whole bunch of tubes and IVs and everything attached to them. Now, this is modern medicine, and it can be modern medicine at its best. If you've been in a serious car accident or had a sudden illness, and you can tolerate this for a short period of time to get back on your feet, or something that you consider to be reasonable, most of us would be willing to put up with that. But if this is happening at the very end of your life, that is a different story. And this is all too often what it tends to look like. For some people, this is what they want, and that's okay. For some people, this is the last thing they want, and that's also okay. This is a picture to really depict that. There's a seriously ill person laying in bed. The Grim Reaper is at their side, and the person is saying, I want a second opinion, right? This is someone who is dying, but they are fighting. They are not ready. They want, is there anything else you can do? Is there something else? As a society, we have come to recognize that for some people, this is what they want, and that is okay. But I'm here to tell you that for some people that are interested in medical aid and dying, their interest comes because they want exactly not that. They don't want to end up in a bed, very incapacitated for the very last few days or weeks of their lives. So if you're catching on, we're talking about diversity, we're talking about individual differences, and we're talking about really respecting that each of us, we only get born once, and we only get to die once, and you don't get a do-over. And for some people, having a say and having some control over how that happens is deeply important. This is a quote from Atul Gawande. You might have heard of him. Our ultimate goal, after all, is not a good death, but a good life to the very end. I talk to a lot of different people who are nearing the end of their life, and everybody is different. I can't say that often enough. But it is really true that there's a lot of commonality. And many people talk about these kind of basic things. Look, if there's a chance that I'm living, or I got to go through some really tough chemo, or be in the hospital and rehab for a long time, but I can get back to something that I find acceptable, that's okay with me. Many people will also say, if I'm dying, what's most important? I'd like to be at home. I'd like to have my family and my loved ones with me. And I want to be reasonably comfortable, however you define that. So pretty simple wishes: home, family and friends around, and comfortable. I have seen a lot of people die, and I am sorry to tell you that it doesn't go that way for a lot of people. And so we have to do better. And one way that we can do better is by doing more talking, by preparing, by not being afraid to talk about what's going on when we're diagnosed with a serious illness or if we're healthy. And the more we talk about things and the more we're not afraid to ask, might this be the end of my life, the more likely it is that whatever it is that's important to you will be present at the end. This says Death by IKEA. Anybody who's an IKEA fan? So this is a reminder, again, that we don't get to choose what illness we get or how we're going to die. And we can die in lots of different ways. And sometimes we can be prepared, and sometimes it can be sudden. Depending on the day that I've had at work, I usually come down on the end of, you know what, sudden isn't so bad. But for many of us, having a little time to say goodbye and our final expressions of love and forgiveness and those important things is really important. So we can hope for that, but we also need a plan to try to bring that about. I want to read you a quote about suffering, and I'm just going to invite you to close your eyes if you're comfortable doing so. And I'm going to read this quote. I'm also going to pop it up there if you want to read it, but it's really powerful. Suffering is experienced by persons, not merely by bodies, and has its source in challenges that threaten the intactness of the person as a complex social and psychological entity. Suffering can include physical pain, but is by no means limited to it. The relief of suffering and the cure of disease must be seen as twin obligations of a medical profession that is truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering in itself. That was written by Dr. Eric Tassell back in 1982, and it's still one of my favorite descriptions of suffering. And then this little circle that I've shown that many of you or anybody that's heard me talk before has probably seen, just a reminder that suffering can have many different dimensions. It comes in different flavors, and there are different aspects to suffering. And just very briefly, there is physical suffering. Most of us are familiar with that, right? Pain or nausea or fatigue. And the truth is that we've made a lot of progress in medicine, and we have good, powerful therapeutic interventions that can help a lot of those physical symptoms, but not always. Then there is the social aspect of suffering. There is I'm a 42-year-old single mother, and I've just been diagnosed with a serious illness, and now I have to go to chemotherapy every 3 weeks, and who's going to take care of my kids? That is suffering. And sometimes the social suffering and the organizing of the way our lives change when we're living with a serious illness is even more difficult to manage and has a more profound effect on us than the illness and the physical symptoms itself. The psychological aspect is for those that may have a history of significant grief, or maybe you have watched somebody die before in a way that wasn't easy or peaceful, and it's made you a little bit fearful of what could happen to yourself. And then there's the existential suffering, which is more about what is the meaning of this illness I've been struck with. And for many people, I'm going to do my best. I'm going to live with this illness. I'm going to tackle every day as I can. But for many people at the very end, they really question, what is the meaning? It's one thing that I can't work on my dairy farm anymore. It's another thing that now I can't even sit at my dining room table, and I'm spending all my time in bed, and I have to have help in turning and getting personal care. For some people, experiencing that at the very end of life has no meaning, and therefore they are suffering, and there is very little that we can do to address that suffering. We can talk about it, we can help people understand that we're all born, we are all creatures on this earth, we all have family and friends who love us and caregivers who willingly will help care for us as our body slows down. We can talk about that, but it's not always the right comfort for that individual who's living with it. I want to mention grief because it's so big, and I love this cartoon of grief because it shows you how when grief first happens, it's like a giant sack of potatoes. It's huge, it's heavy, it's overwhelming. You can't even lift it, let alone get around it. But if we have the right supports, and with time, grief changes over time, and it can become something that's more manageable. So you see it turns into a little grief case, which is a little easier to carry around, and it comes with you. And if you're really successful, it gets to a point where it's a nice little purse. It doesn't go away. It's still a part of you and who you are, but it takes less of your energy and it's less present. However, when you are diagnosed with a serious illness or somebody you love has a serious illness, that grief can go right back to a big sack of potatoes. And grief and unmanaged grief and fear of grief and the anticipatory grief are all things that are really present for many people toward the end of life, and we don't always attend to it enough. So just something to keep in mind. And this is another of my favorite cartoons. It's two people looking at exactly the same thing, but they're seeing very different images. So the person on the left sees 4 sticks, the person on the right sees 3. Each of them factually seeing exactly what is there. They're in the same place at the same time. This is just really important to keep in mind. What we see in our perspective is not going to be the same necessarily as the person on the other end of the table or the chair or the dining room. And so the biggest lessons I've learned in doing the work that I do is just the need to be very humble and curious and always asking questions about the other person's perspective and thinking about how it could be different from your own. All right. All that stuff is really, really important, and we haven't even gotten to talking about medical aid in dying, but it's the preamble and the foundation of what brings us to this point. So what is medical aid in dying? It's a practice that allows, in Vermont and in most states, it has to be a physician, not everywhere, to prescribe a lethal dose of medication for a capable, terminally ill patient with a less than 6-month prognosis to voluntarily administer for the purpose of hastening death. So there's a lot of really important things in there. This is something that is driven by the patient. It is voluntary, and the patient is in control through the whole process and can stop at any time. The patient has to be capable of understanding their illness and their treatment options and what would happen if they took medications to hasten their death. And you have to have a terminal illness and be in the final phase of that illness. Now, we all know that this word prognosis is a big word. It's an inexact, educated science. So prognosis is about foretelling or imagining what will happen in the future. So as doctors, when we're thinking about what kind of treatment is best for you, and because hospice requires a less than 6-month prognosis, we have to have some kind of a time frame to get us into the court of what's a reasonable period of time in which to allow medical aid in dying. It's an inexact science. Absolutely, people sometimes live longer, and that's a very good thing. There's nothing wrong with that. I will also tell you that doctors are not very good about it. And in fact, there are several studies that show we often overestimate by as much as a factor of 5 how long people have to live. We're trying to strike the right balance. But for many patients, they feel like they're getting stuck on one side or the other, and that speaks to the challenges of life in general. So the process itself that you would have to go through if you were interested in considering medical aid in dying, and I think it's really important to keep that word in mind, considering. Even people who are asking for it, who've gone through the whole process, nobody knows for sure if the patient is going to take that medication, but they want to have the option. And so even as we're talking about medical aid in dying, we're also continuing to talk about what else is giving your life meaning? What else can I do for your pain? How can I help your daughter understand what you're going through? So it is in parallel to the very best possible end-of-life care that you're getting from the rest of your providers. So you have to see a physician once and make a verbal request. That can be done in person, and because our law has been updated, it can also be done over telemedicine if the prescribing physician feels comfortable in their ability to evaluate your request over telemedicine. That has to have video and sound. Then, at least 15 days later, so that means more than 2 weeks, right? So if you make your request on a Monday, your next appointment's going to be 2 weeks Tuesday. That same physician, you have to make a second verbal request. To be eligible to start the process, you have to have been given a 6-month prognosis. And so that's why I was mentioning before sort of the challenges around truth-telling and sometimes some tough news, and remembering that a prognosis is an estimate, not an absolute fact. So, for example, you could be living with advanced cancer and really hoping that this new experimental treatment that you're going to Dana-Farber for will help you live longer, maybe even help cure you, and you still could have a 6-month prognosis, meaning there's still a good chance that your initial hope won't come to pass and you would still be eligible to start the process. But somebody, but importantly, the prescribing physician has to believe you have a 6-month prognosis to start the process. I'm seeing a shaking head, which means this is something that's a safeguard, but it also feels like a barrier. So I would just acknowledge that. So you've made your first request and you've made your second request of your prescribing physician. Along the line, and it could be just before those visits or during those visits or just after both of those visits, you have to see a second doctor. The purpose of that visit is for them to confirm that you are living with a terminal illness and that you do have a less than 6-month prognosis and that you understand your treatment options. The patient also has to put their request in writing. So you have to write down that you understand you're living with a terminal illness and that you are interested in having the medication as an option. Much like when you get diagnosed with ALS, you might meet a neurologist for the first time, or when you get diagnosed with cancer, you might meet an oncologist for the first time. If you're interested in medical aid in dying, but the people who are already taking care of you are not willing or aren't sure if they want to prescribe, you might meet a doctor for the first time to make your request. So there is no requirement of how long you need to know the person or what their specialty is. Anybody who's meeting somebody living with a serious illness, who's a physician who has training, is trained to do a thorough assessment, to review your records, do a physical exam, and to make their own judgment. If you do the entire process via telemedicine, the prescribing physician must refer to and have an in-person physical exam documented, but it could be done by somebody else. So the question is around the timing of when you could start this process. And let's say you've been diagnosed with a serious cancer. And like some people are familiar with the stages of cancer. So sometimes we talk about stage 4 cancer. That means it's later stage, that the cancer has spread from where it started. So whether or not you decide you want active treatment for your cancer, if your cancer is serious enough that it's possible that you might not be alive in 6 months, you can start this process with or without active treatment. Now we're getting into the weeds, but this is really important, so bear with me. Like, I'm a doctor. Many of my friends are oncologists. I also like to give them a hard time, and they know that. And I would say these same words if my oncology colleagues were sitting right beside me on the stage. So oncologists, just as an example, we want them to be hopeful and smart and thinking really hard about what kind of treatments could help you. That's their job. Sometimes they get so focused on their hope for you that they are a little bit on the optimistic side about what the treatment like chemotherapy could actually offer you. So sometimes you might hear that, well, if you take this chemotherapy, you're going to live 4.3 months longer than if you don't take it. Well, that is a piece of information, but it's not the whole story. So again, I would encourage anybody who's interested in living and getting treatment for anything to feel comfortable having a dialogue with your physician. You're saying 4.3 months. Where does that number come from? And how do you know that? But I'm also living with a little heart failure, and my friend who got this cancer actually died just a couple of weeks after her diagnosis. So there's a variety of ways it could go, right? Like you sometimes, if you really want it, have to really say, I know this is hard information. I know that there's no exact answer, but I really need to know as much as you know so that I can make the best decision for myself. Just some common things about medical aid in dying just to keep in mind. Some people, like I said before, never want to use it, don't even want to hear about it. I believe that everybody is comforted by having many tools in the toolbox, and that everybody in the state of Vermont, and now everybody across the country who might be interested in coming to Vermont, knows that we have this option in case you might need it. Some people start the process but never complete it. Some people get through the whole process and they are deemed eligible and can get the medication, but never get the medication and never use it. And even for the people that use it, it is a very small percentage of the people who die in our state every year. So it is a really powerful and important tool that is used for a small but important number of people. And remember what I said before about like the things that people wish for if they knew they were dying, those kind of simple things about being at home and being surrounded by loved ones and being comfortable, however you decide that. Well, we can have a lot of discussions about how else you might be able to achieve that. But I can tell you universally, the medical aid in dying deaths that I have prescribed for and been a part of have achieved those three simple things. And they can be, as we're going to hear very soon, quite beautiful. Here was another great quote from Atulba one day. Life is meaningful because it is a story. And in stories, endings matter. So I'm going to ask Ellen just to tell us a little bit about you and Willem. So, Willem, some of you knew Willem. He was the representative in the State House for many years. Some of you have a picture of him. He was incredibly energetic, super positive, extremely fit, everywhere all at once. And we got together in early 2018 and decided to get married in November of 2020. And 2 weeks after we decided to get married, we found out that she had stage 4 mucosal melanoma, which is melanoma in your mucosal tissues. And he had had non-Hodgkin's lymphoma about 10 years earlier. He had a super successful recovery from that. And this diagnosis came completely out of the blue. And he wanted to go down to Dartmouth-Hitchcock for his treatment. We started seeing the fantastic team at Dartmouth-Hitchcock. And had about 14 months until he died. And those 14 months were like absolutely full of beautiful things. Super travel, beautiful adventures, tons of family, a wedding. And then it was, the fall of 2021 when things were going, all of the treatments that had been prescribed to him were not having the desired effect. Back up one minute. So Willem was in the House, the Vermont State House, in 2013 when the initial legislation for medical aid in dying took place. And Willem was one of the people who was a sponsor of that bill, exactly, and worked with Diana on that bill, and was very, very proud of his work on making sure that option was available to all Vermonters. And so in June, the June before he died, Willem died in January of 2022. And the June before, he brought his family together, me and his girls and his ex-wife, Jean, and said, look, this is where we're at. We may be able to get some good treatment here, we may not. And if
I can't, if the treatment doesn't go the way that I want it to go, I want to be able to use this medical aid in dying prescription. And he said, I just really need you all to support me in that. And of course, we were like, yes, we will support you, whatever you want to do. You know, Willem was the driver. He was the driver of this whole story. So he knew he had us. He knew he had our support. He knew he wasn't going to get any pushback from the people in his life if he decided to use this option. And I think it was December of 2021 when he reached out to Diana, and he was getting sicker and sicker. And he reached out to Diana and said, hey, I think I'm going to need your help. And Diana came to our house, and Willem said to her, I need you to be honest with me. Do you think, look at me and tell me what you think. And Diana, and I remember it so vividly, she was so honest. She said, Willem, I think it's really clear. She asked him questions, and, she was like, but she knew Willem. She knew Willem as a healthy person. And when she saw him in December, she knew that it was clear that his death was coming sooner than anybody would have wanted. And that was helpful to have that honesty, because our wonderful team at Dartmouth Hitchcock was so full of possibilities. Oh, maybe we can try this, maybe we can try that. And it had gotten to the point where Willem was having a hard time getting in the car to go to Hanover, right? And he was thinking, wow, maybe it's time to just get this prescription in case I need it. And so the prescription process happened. His oncologist said, yes, in fact, you have less than 6 months to live. Diana confirmed that as the second physician. We got this prescription from, this wonderful pharmacy in Rutland that does all these prescriptions. And only then did we start hospice care. It was like the Wednesday before he died, we started hospice care. And we had beautiful hospice care. Brought in a hospice bed and oxygen and lovely visits from a lovely hospice nurse. And we started telling people that it was time to come and say goodbye. And everyone, we had so many visitors. And Willem was absolutely Willem through the whole process. He was funny. He was making people feel comfortable. And he had that opportunity to say what he needed to say to the people that meant the most to him. And I had a calendar, who's coming when, and it was beautiful. It was actually beautiful. And then we woke up one morning that morning, and he said, I don't think there's going to be a tomorrow. And I said, okay, this is your choice. And he said, can we get the hospice nurse and Diana to come this afternoon? So we put that off in place. And Diana arrived, and all of our kids were there, beautiful friends, everyone, and I met them. And Diana was able to be right there with us, and and Willem, the concoction of medication, when she went downstairs and she looked through her cupboards and she said, Willem, I found this nice little citizen cider glass. Do you think that's an appropriate glass? And Willem said, Willem was in bed and he was pretty comfortable. We were lucky. Willem didn't have tons and tons of fees. And he said, I still don't understand why I can't do this with a good beer. And it was scary for me because you have to be able to drink 4 ounces of this stuff, right?
And we're down to 2 ounces now, but back then, was that right? 4 ounces. Oh, yes.
And Willem had not had anything to eat or drink in several days, 3 or 4 days anyway, and I was not sure that he was going to be able to drink this 4 ounces of probably awful tasting stuff, And he thought he took the glass from Diana and he drank it down, and I was stunned. And he settled himself back into his pillows, and his girls were there, and all of our people were there. And he made a little heart shape with his hands at his girls. And I settled back in and closed his eyes and sort of turned his head towards the window that was right side of bed. And his last words were, already flying. And he just flew out that window. And it was graceful, and it was calm, and there was no tense pain, awfulness. I was afraid there was going to be some sort of awful struggle, and none of that. It was beautiful and calm, and we were incredibly, incredibly grateful. He was incredibly grateful. And I know his girls, for me and his girls, knowing that this was an option was a gift that we had been given.
Let the life I've lived speak for me. Let the life I've lived speak for me. When I come to the end of this road, and I lay down my heavy load, let the life I've lived speak for me. Let the friends I've made speak for